Well, thanks for having me back to Las Vegas and to speak with you today about advances in treatments for gliomas. I think there have been a couple since I was at least in Las Vegas 5 years ago, so we'll see what you think. These are my disclosures, which are also listed in your program. So let's start with glioblastoma. So glioblastoma is the most common primary malignant brain tumor. It is still a pathological diagnosis. The four cardinal pathological features are on this slide. It's what our neuropathologists look for. They look for cellular or nuclear pleomorphism. They look for mitotic activity. They look for microvascular or endothelial cell proliferation, these pink cells, or they look for necrosis. So there's a necrotic core here surrounded by these cells. This is called pseudopalisading necrosis. So you add 1, 2, 3, 4, and that's a glioblastoma. Not a very difficult diagnosis for our colleagues in pathology to make. Now, we have learned that glioblastoma, as with many solid tumors, consists of multiple molecular subsets. The TCGA tackled glioblastoma as one of the first solid tumors in terms of looking at genetic events, and they classified the disease into 4 subtypes based on various genetic alterations. Names are not that important, but there are at least 4 classes of glioblastoma. This has made it is beginning to make its way into the clinical trial design space, but this is not validated and this is not yet being used really in clinical practice, but in the future it might be. Again, I said this, the most common primary malignant brain tumor. It's the most common glioma subtype, estimated about 12,000 new cases every year in the United States. It's the first or second leading cause of cancer death among young adult males in the U.S. However, the median age of diagnosis for this tumor is 64, and if you look at population statistics, the median survival is still under 1 year, and 5-year survival is almost unheard of. We've learned that there are a number of prognostic factors which we try to take into account when we're designing randomized trials. Age is a big one, performance status. An important one that's emerged in the last decade is this 0,6-methylguanine DNA methyltransferase gene. This is a mediator of resistance to alkylating drugs. So when this is turned off, that's when the promoter is methylated. So methylated MGMT means that it's present in low levels or it's absent. That's a good thing because there's less resistance to alkylating chemotherapy. So MGMT status is now routinely screened for in most institutions. We've also learned that the isocitrate dehydrogenase 1 gene is important. Mainly in low grades. It's more common in low-grade gliomas, but it's also present in about 5 to 10% of glioblastomas, and it's a positive prognostic marker when it is present. The gold standard in terms of diagnosis is an MRI. You can see that this is an MRI, an axial view here with after contrast. And some of the classic features of the tumor include very ill-defined or indistinct borders, necrotic interior of the tumor, and a fair amount of mass effect. These can be rapidly progressive. Here's a patient who presented with a seizure. This little small cortical lesion here was discharged and came back 2 months later and has this necrotic mass, and it turned out to be a glioblastoma. There are some guidelines, and these are rather vague and they're not really validated, but we do have to push back with some of our insurance companies sometimes about imaging frequency in these patients, and we often cite the NCCN imaging guidelines. So the recommendation is to obtain an MRI with contrast with each of these 2 to 6 weeks after the completion of radiation, and then every 2 to 4 months for the first 2 to 3 years of follow-up if the patients are fortunate enough to make it out that long, and then quote-unquote less frequently. So it's dealer's choice after 3 years. This is a phenomenon that we recognize more commonly in the era of chemoradiation when we're combining temozolomide and radiation. This is the phenomenon of pseudoprogression, and it's illustrated really in this case of mine here. This is a patient who had a left occipital glioblastoma resected. There was a large tumor here. It's almost all gone. Patient goes on to receive radiation and temozolomide after their resection, which is standard of care. And then the first MRI after radiation, this was done about 4 weeks after radiation, you can see there's a lot more enhancement. There's more mass effect. The patient was having some symptoms. We thought this might be tumor progression. A PET scan was done. It's hypometabolic over this region. Biopsy was performed, and it was bland necrosis, so this is a treatment-related effect. And it's seen, there are various estimates in the literature, but it's seen anywhere from 20 to 40% of the time. This is an extreme example after radiation. There are variable levels of this, but it tends to be in the first 3 months, that window from finishing radiation. And there's really nothing to do for it if it occurs. This is the same patient. We just continue temozolomide in this patient. You can see that over time, it gets better, 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 and eventually it's almost all gone away with time. About a third of patients are symptomatic, and if they are, they can be treated sometimes with steroids. If they're not symptomatic or minimally symptomatic, there's really no reason to treat this. You just continue standard of care. So let's talk about treatment of newly diagnosed glioblastoma. So we're going to walk through surgery, radiation. I won't say much about radiation today. I'm going to focus on surgery and mainly chemotherapy, in the interest of time. So let's talk first about surgery. So what's the rationale for putting someone through a craniotomy, a big operation in the hospital for a week or so? Well, obviously we need tissue for pathological diagnosis. And in the era of more and more molecular testing, we are also profiling many of these tumors. We at a minimum want to have MGMT status, et cetera. So it allows adequate tissue to achieve that. Many patients will have improvement in their neurological symptoms and signs after a debulking procedure. Often this will allow one to reduce or eliminate steroids in these patients, and it may also allow them to better tolerate radiation. What had been controversial is whether an aggressive surgery for glioblastoma improves survival. And up until a few years ago, really all we had was retrospective data that spoke to this. But it did indicate, or it did suggest that patients who had resections did live longer. This study came along just a few years ago. This was a study conducted in Europe of an agent, aminolevulinic acid. And so the idea here is aminolevulinic acid, or ALA, is a non-fluorescent prodrug. It's taken up by dividing cells, in this case glioma cells, and is then converted to a fluorescent porphyrin. So when the surgeon puts a lens, a special lens on his operating microscope, his or her operating microscope, it turns the tumor purple or pink. The idea being that it would allow the surgeon to do a more complete aggressive resection. It's very safe. And so there was a randomized multi-center phase 3 trial of this in patients who were newly diagnosed with brain masses that looked like malignant gliomas. And the trial basically showed two things. Number one, those patients who received the ALA had a 65% proportion of gross total resection. That's taken out everything you can see on the MRI, versus 40% in those who did not receive ALA. In fact, this was an interim analysis, and the trial was closed early because it was a highly significant difference. The other interesting thing that it showed that there were 243 glioblastomas, and those who had gross total resections had a median survival of almost 17 months versus 12 months in those who had a subtotal resection. So there was a significant improvement in survival in glioblastoma patients who had a gross total resection, supporting what we had suspected all along, really with retrospective data. So surgery does matter and does help and does improve survival. I'm not going to cover fractionated radiation, but it is part of the standard of care. It's usually 6 weeks, 60 gray. It's focal, fractionated, daily radiation, 30 treatments over 6 weeks, combined with temozolomide. I'll talk a little bit about temozolomide. This was a study now that's about 10 years old. This was the study that got it approved. This was done in Europe mainly. This was a randomized trial, newly diagnosed glioblastoma patients after their surgery were randomized to receive either 6 weeks of radiation alone or 6 weeks of radiation and daily temozolomide, followed in that arm by 6 months of adjuvant temozolomide. These are the results, again, published about 10 years ago, over 500 patients. Survival in the radiation arm, 12 months. Survival in the chemoradiation arm, 15 months. This was statistically significant. These patients now have been followed out multiple years, and you can see that this survival advantage holds up at year 2, 3, 4, and 5. So this led to approval of temozolomide, rapid incorporation of this agent into standard of care in clinical practice. So it changed the standard of care in glioblastoma. What has been debated is how much adjuvant temozolomide should be administered. after that 6-week period with daily temozolomide irradiation? Should you give 6 more months, 12 months, indefinitely? We don't have any randomized data that compares 6 months versus 12 months or any other time. But what we do have now is we have 4 randomized trials that have looked at various durations of temozolomide after radiation. There are 3 that have looked at 6 cycles or 6 months of temozolomide. Others have allowed up to a year. And you can see that if you look at overall survival, the 6-month group, 15 to 17 months, not much different than the group that gets it out to 12 months. So it's certainly defensible and probably desirable to give 6 months of temozolomide after the completion of radiation. Glioblastoma is a highly vascularized tumor. If you look at, in fact, microvascular proliferation I showed you earlier is a requirement for the diagnosis of glioblastoma. If you look at things like vascular endothelial growth factor, ligand, or receptor, the levels of those agents, or of those molecules, correlate with the grade of the glioma. So the higher the levels of VEGF receptor, the higher the grade of glioma. And so on the surface, it's an attractive target for angiogenesis targeting agents. In fact, I'll come back to this, but bevacizumab was approved as monotherapy for recurrent glioblastoma in 2009. That approval in 2009 was contingent upon subsequent studies of bevacizumab showing a survival advantage. And these studies were done in the newly diagnosed glioblastoma setting. So both of these trials were published back-to-back in the New England Journal within the last year. The design of both were the same. There was an RTOG study done mainly in the US and Canada, and an AVAGLIO, which was done in Europe. Basically, the idea again here, newly diagnosed glioblastoma, you have your surgery, your biopsy, then you're randomized to receive bevacizumab with temozolomide and radiation versus a placebo with temozolomide and radiation. The results of both the trials were nearly identical, and they are really highlighted in this RTOG slide taken from the paper in the New England Journal. The patients who received bevacizumab had improved progression-free survival, statistically significant, but no improvement in overall survival versus those with placebo. Same result in the AVAGLIO study. So these were disappointing results, to say the least. Just skip that. Now, it turns out that the study designs were such that there was crossover of bevacizumab into the placebo arm in a very high percentage of both trials. In the RTOG trial, in fact, it was mandated that at the time of progression, if you were on placebo, you crossed over to receive bevacizumab. That was not mandated in the AVAGLIO, the European study, but it turns out 75% of patients crossed over and received bevacizumab. And the question is, could that have obscured an overall survival advantage in the bevacizumab group? So this was an interesting look at this, presented just a few months ago at our neuro-oncology meeting. And what they took the 25% of patients in AVAGLIO who did not receive any subsequent bevacizumab in either arm. There were 105 in the placebo arm, 120 in the bevacizumab arm. And you can see if you look at overall survival, there was about a 50% increase in overall survival in those who received bevacizumab versus placebo. Now, of course, this is subset analysis, et cetera, but it does, I think many of us in the field believe that there probably was an opportunity to observe an overall survival advantage of this drug in this setting, but it may have actually been confounded or obscured by the fact that many patients received bevacizumab at the time of progression. Okay, let's switch gears now and talk about recurrent glioblastoma. Regrettably, almost all of these patients recur usually within the first 1 to 2 years. So what do? We put everything back on the table, repeat resection. There is a BCNU releasing wafer polymer that's available that the surgeon can put in at the time of a repeat resection. It's FDA approved for this. You can think about radiation. There's no class 1 evidence that suggests that radiosurgery or reirradiation is beneficial, however. Medical therapies, lomustine is a drug that's kind of come back from the grave in this disease. It was served as a control arm in several randomized trials recently and has performed pretty well. So this is an option. And of course, bevacizumab is still approved as a monotherapy in this disease setting where you can get about 40 to 50% of patients progression-free survival at 6 months. This is the setting when most patients, however, do go on to clinical trials. Let me say a word about the bevacizumab story in recurrent glioblastoma because it still is FDA approved and is commonly used. The majority of the patients in the U.S. receive bevacizumab at the time of recurrence. This is one of the earliest studies done at Duke University. 35 recurrent glioblastoma patients failed radiation, temozolomide surgery. They recurred, and they were given bevacizumab, in this case with irinotecan. And you can see progression-free survival, almost 50%. The historical expectations about 15 to 20%, so quite good. And over half of the patients were like this. They had an objective radiographic response. You can see here, this is the same patient. This is an axial coronal MRI showing the tumor before treatment and the tumor after treatment. This, along with several other smaller studies, led to this randomized, non-comparative study, randomized phase 2 non-comparative study in recurrent glioblastoma, in which patients at the time of their disease progression were randomized to bevacizumab alone or bevacizumab and irinotecan. And the results were as follows. About 30 to 40% had objective radiographic responses, much better than you see with standard chemotherapy, which is in the order of about 5 to 10%. And 40 to 50% of patients had no disease progression at 6 months. Again, much better than you would predict. So based on this randomized non-comparative phase 2 study, the FDA granted approval for bevacizumab as monotherapy for recurrent glioblastoma. It remains to be seen what will happen with these negative trials up front, but as of today, the drug is still available and still widely used. So there is maybe a final opportunity to see if there's a randomized phase 3 trial that's still actually just finished accrual that may answer this question with respect to survival. This is the BLOB study being done in Europe. It started off as a randomized phase 2 trial, and there were basically 3 treatments. These were all patients who've had disease progression, and they were given bevacizumab alone, or they were given CCNU alone, or they were given the combination of both. And if you look at this column right here, these are the results that were published in Lancet Oncology a few months ago. The overall survival at 9 months, which is a metric that we sometimes use, you can see that the combination arms had a superior OS9 versus either of the monotherapy arms. Now, again, this wasn't powered to do a formal comparison, but this led to the conversion of this randomized phase 2 trial to a formal phase 3 trial. This is the EORTC trial. 2 arms in this trial. So recurrent glioblastoma, and they either receive the combination of CCNU and bevacizumab, or they receive CCNU alone. That trial has just finished accruing, and we may get a readout as early as the end of this year, if not certainly early 2016 in time for ASCO next year. So we shall see what happens with bevacizumab in recurrent glioblastoma. A lot of interest in immunotherapy in multiple solid tumors. Again, like the previous speaker, this is not felt to be a very immunogenic tumor. There's not a lot of T cell or immune cell infiltration of these tumors, but there has been some interest in this, and this is one of the studies that, again, served as the basis of a randomized phase 3 trial that has just finished accrual. So the idea here is that these are about 20% of patients with glioblastoma will have an mutation in the EGFR gene, so-called EGFR V3 mutation. And so these patients are were selected for this trial at Duke, in which they created a peptide vaccine of EGFR V3 and vaccinated these patients at the time of recurrence and resection. And these blue curves, or progression-free and overall survival, are the vaccinated patients. And these are matched controls. This was not randomized, but there were matched controls for degree of resection, et cetera, who did not receive vaccination but did have resection. You can see that those patients who received the peptide vaccine had improved progression-free and overall survival, really, versus that historical cohort. This led to the design of this trial, which is just finished accrual. So this is basic idea here is that this is a placebo-controlled trial where there's active vaccine in one arm, a placebo KLH antigen in the other arm, and they're combining it with temozolomide after the completion of radiation. This has completed accrual, and again, this year we should see a readout on this trial. So 2 trials that we hope may change the standard of care in glioblastoma. Again, we shall see. Okay, let me wrap up by talking about 2 other types of gliomas. So this is anaplastic oligodendroglioma. This is about roughly 10% of all gliomas diagnosed in the U.S. every year, probably somewhere on the order of 3,000 to 4,000 new cases a year. It's an interesting subtype of glioma because it's chemosensitive. So this, most of these are contrast-enhancing lesions on MRI. They have a characteristic pathological appearance, so-called fried egg appearance of these nuclei. It's actually an artifact. And about 70% of these patients will have chromosomal loss of 1p and 19q. And this has actually become routine now in the pathological workup of these patients. What was noted by investigators in the late 1980s, early 1990s, that these cases had quite variable outcomes. Some did very, very well. Some did very poorly. Moreover, this radiation had been the standard of care for these tumors, but it was shown in several studies that up to 80% in some small studies had partial responses or even complete responses to the PCV regimen, procarbazine, CCNU, and vincristine. Moreover, 1p, the chromosome 1p deletion, seemed to predict which patients did respond to chemotherapy. So it begs the question of, would adjuvant PCV improve survival in anaplastic oligodendroglioma? So 2 randomized trials were developed, executed. One was a European study. These were newly diagnosed cases, randomized to radiation alone versus radiation followed by 6 cycles of PCV. And then there was the RTOG study, a bit of a different design. They were randomized to radiation alone versus PCV first, followed by radiation. These were originally published in 2006, and the results were the same in the 2 trials, that chemotherapy improved progression-free survival in both trials, but there was no difference in overall survival in the radiation arms versus the radiation and chemotherapy arms. However, these data continued to mature, and they were looked at again just recently. And remember, this is 1p19q, or the group. This is about 70% of all anaplastic oligos. And this is supposed to predict for chemosensitivity. So they looked at this group of patients who had 1p19q deletion and long-term follow-up. And interestingly, those patients who had received chemotherapy with radiation versus radiation alone, these chemotherapy patients had a doubling of their survival with long-term follow-up. So about 15 years versus 7 years. And this was seen in both studies. This was seen in both the RTOG study as well as the EORTC study. So this really prompted many in the field to advise that patients who have anaplastic oligodendroglioma should receive not only surgery and radiation, but also chemotherapy. Another interesting subtype of glioma is low-grade glioma. It's a common term that includes a lot of subtypes. So we're talking low-grade astrocytomas, low-grade oligodendrogliomas, et cetera. But there was a trial that was designed in the 1990s and started then. And they basically took these low-grade gliomas, patients, and typically the standard treatment at that point had just been a resection, resecting the patient and then observing and treating at the time of progression. That's what most oncologists, neuro-oncologists did at that time. But they tried to define a group of these patients that had an inferior prognosis, where the tumor would grow back sooner. So they defined this high-risk group of low-grade gliomas, and their definition was rather simple. High-risk low-grade gliomas are any patients over the age of 40 who have a diagnosis of a low-grade glioma, or patients less than the age of 40 who have an incomplete resection, so they have residual macroscopic disease on their MRI. So they treated these patients more aggressively. So in this trial of 250 patients, they were randomized to receive, after their surgery, radiation alone or PCV and radiation. And the first publication was just like anaplastic oligodendroglioma. There was an improvement in progression-free survival, but no improvement in overall survival. But with longer-term follow-up, this was just presented at ASCO this past summer, the overall survival in the chemoradiation arm is 14 years. versus 7.8 years or 8 years in the radiation alone arm. So this is something that we're still kind of grappling with in terms of, you know, the implications for practice, because again, this study being done more than 17 years ago when it was started, we didn't even know about IDH1 mutations. 1p19q was not incorporated into this study. So there are a lot of factors here at play. Moreover, we don't really use PCV much anymore. We now use temozolomide. So is temozolomide equivalent to PCV? So it begs a lot of questions. There is an ongoing RTOG study that's going to take several more years of accrual and follow-up that has now incorporated a PCV arm, a radiation arm, and a temozolomide arm in low-grade gliomas. So we'll see eventually what happens there. So in conclusion, glioblastoma, we are using molecular markers of prognosis more commonly. We do recommend resection if feasible, followed by chemoradiation. It's now the standard of care. Bevacizumab or chemotherapy, CCNU seems to be the most common, could be considered standard of care at recurrence. We're expecting the results of 2 randomized trials this year that will further define the role of bevacizumab, as well as the first peptide vaccine that's made it through a phase 3 trial in gliomas. The addition of chemotherapy to surgery and radiation extends survival in anaplastic oligodendrogliomas with 1p19q loss. And finally, the addition of chemotherapy to surgery and radiation appears to extend survival in high-risk, low-grade glioma patients. Thank you very much.
Tracy, we have a couple questions.